Hello, and welcome back to another chapter of Advanced Pathophysiology, Alterations of Neurology, Function in Children. Here, our pages are not going to line up perfectly, as I'm only reading page 619 through 625, and then 633 through 641. So, we'll see how that follows along. 625 is, I guess, after the malformation of brain development finishes. So, neurologic disorders in children can arise anytime before birth, through adolescence, and include congenital malformations, genetic defects in metabolism, brain injuries, infection, tumor, and other disorders that affect neurologic structure and function. The symptoms, diagnosing, management, and neurologic disorders in children are often different from those of adults, even with similar disorders. Development of the nervous system in children, both genetic and environment shape development of the nervous system. Because the brain development starts in the first days of embryonic development, maternal factors, including lifestyle, nutrition, exposure to toxins or infection, and state of health have crucial effects on the developing nervous system. The nervous system develops from embryonic ectoderm through a complex and sequential process, including 1. The formation of the neural tube, 2. Development of the forebrain from the neural tube, 3. Neuronal proliferation and migration, 4. The formation of network connection and synapses, and 5. The myelination. Formation of the neural tube begins between 3 to 4 weeks of gestation as the neural plate folds to form a neural groove and neural fold. The neural groove deepens and closes dorsally to form the neural tube, which gives rise to the entire central nervous system. The neural tube closes first in the cervical region and then sippers in two directions, cranially and caudally. So here we have that neural tube at 3 weeks of gestation. The caudal end of the neural tube forms the brain, and the remainder develops into the spinal cord. The lumen of the neural tube becomes the ventricles of the brain and the central canal of the spinal cord. Some neuroectodermal cells separate from the neural tube, but remain between the tube and the surface ectoderm, creating the neural crest. This cellular band develops into the peripheral nervous system. On either side of the neural tube's inner surface is a longitudinal groove. Anterior to the region, the gray matter differentiates into the nuclei of the lower motor neurons. The regions posterior to the sulcus and differentiates into the sensory nuclei of the spinal cord. So here we're taking a look at the sulcus limitans and alar and basal plate. The growth and development of the brain occurs rapidly during the third and fourth month of gestation, and again from the fifth month of gestation through the first year of life, reflecting the proliferation of the neurons and glial cells, although most of the neurons that an individual will have are present at birth. Development of skills such as walking, talking, and thinking depends on these neurons making correct connections with other neurons and on the myelination of the axons making these connections. The head is the fastest growing body part during infancy. One half of postnatal brain growth is achieved by the first year and is 90% complete by the age of 6. The cortex thickens with maturation and the sulci deepens as a result of rapid expansion of the surface area of the brain. Cerebral blood flow and oxygen consumption during these years are about twice those of the adult brain. Structures arising from the mesoderm include blood vessels, microalgia cells, dural and arachnoid layers of the meninges, the capsules of some peripheral sensory nerve endings, and peripheral nerve covering. The bones of the infant skull are separated at the suture lines, forming two fontanelles, or soft spots, one diamond-shaped anterior fontanelle and one triangular-shaped posterior fontanelle. The unclosed sutures allow for expansion of the rapid-growing brain. The posterior fontanelle may be open until 2 to 3 months of age. The anterior fontanelle normally does not fully close until 18 months of age. Head growth almost always reflects brain growth. Monitoring the fontanelles and careful measurement of the head circumference on standardized growth charts are essential elements of the pediatric exam. So here we're taking a look at the cranium sutures and fontanelles in infancy. Because of the immaturity of much of the human brain forebrain at birth, neurologic examination of the infant detects mostly reflex responses that require an intact spinal cord and brainstem. Some of these reflex patterns are inhibited as cerebral cortical function matures. These patterns disappear at predictable times during infancy. So, here are some reflexes of infancy: stepping, moro, sucking, rooting, palmar grasp, plantar grasp, tonic neck, neck riding, landau, and parachute reaction. So most of these start at birth, some at 2 months, 4 to 6 months, 3 and 9 months. And they should no longer be obtainable at 6 weeks, 3 months, 4 months, 7 months, 4 to 7 months, 6 months, 10 months, 5 months, 2 years, and some persist till life. The absence of expected reflex responses at the appropriate age indicates general depression of the central or peripheral motor function. Asymmetric responses may indicate lesions in the motor cortex on the contralateral side of the brain, or may occur with fractures of bones after traumatic delivery or postnatal injury. As the infant matures, the primitive reflexes disappear in the predictable order as voluntary motor functions supersede them. Abnormal persistence of these reflexes is seen in infants with development delays or with central nervous system lesions. So, your structures or structural malformation. The CNS malformations are a common cause of significant morbidity and mortality in the first year of life. Malformations include defects of neural tube closure, your neural migration, and flow of CSF. Oh, that doesn't make sense. Malformations include defects of neural tube closure, formation of the skull and surrounding structures, neural migration, and flow of the CSF. There we go. Now it makes sense. Defects of neural tube closure. Neural tube closure or neural tube defects are the most common anomaly of the CNS. They occur in about 3,000 pregnancies in the US each year, although there are significant regional differences in prevalence. Maternal folate deficiency had been associated with significant risk for neural tube defects. These defects originate during the first month of embryonic development, when the neural tube fails to close completely. Fetal death often occurs in the more severe cases, thereby reducing the actual prevalence of neural defects at birth. In 1996, the US mandated folate fortification in many foods, and since that time, neural tube defects have decreased 20 to 30%. Guidelines are available for folic acid supplementation for women at high risk for neural tube defects. Defects of neural tube closure are divided into two categories: the anterior midline defect and the posterior defect. Anterior midline defects may cause brain and face abnormalities in the holoprosencephaly spectrum, with the most extreme form being cyclopia, in which the child has a single midline orbit and eye with a protruding nose-like proboscis above the orbit, Posterior defects result from failure of closure of the neural tube and results in a variety of myelodysplasias, depending on the level of failure. Although myelodysplasia is defined as a defect in formation of the spinal cord, the term is used to refer to anomalies of both of the vertebral column and the spinal column. Spina bifida is the most common neural tube defect and includes anencephaly, encephalocele, meningocele, and myelomeningocele. Disorders of embryonic neural development are summarized here in figure 20.4. So here you see disorders associated with specific stages of embryonic development. Hit pause if you need a refresher from your anatomy courses here. Anencephaly without brain is an anomaly in which the soft, bony component of the skull and part of the brain are missing. This is a relatively common disorder, with an incidence of approximately 1 per 4,860 lives in the US each year. These infants are stillborn or die within a few days after birth. The pathologic mechanism is unknown. Diagnosis is often made prenatally using ultrasound or evaluating maternal serum alpha fetoproteins. Encephalocele refers to the herniation or protrusion of various amounts of brain and meninges through a defect in the skull, resulting in a sac-like structure. The incidence is approximately 1 in 10,000 live births in the US each year. Encephalopathy occurs during the first weeks of pregnancy, when the defect contains only meninges. It is referred to as a cranial meningiocele. Most encephalopathies, which contain neural tissue as well as meninges, occur in the occipital area, with the remainder found in the frontal, parietal, or nasopharyngeal region. If the defect is located in the nasopharynx, no external anomaly is visible, but the child may experience nasal airway obstruction. On examination with a nasal speculum, a smooth round mass will be visible in the nasal passage. A frontal encephalopathy may extend into the orbit of the eye and produce proptosis of the affected side. An occipital encephalopathy may be associated with other findings such as blindness and cognitive impairment. The size, location, and involvement of the encephalopathy help determine the child's development and intellectual outcome. So here we're taking a look at the meningioencephalopathy of the occipital region. Meningocele is a sac-like cyst of the meninges, filled with spinal fluid and is a form of spina bifida. It develops during the first 4 weeks of pregnancy when the neural tube fails to close completely. The cystic dilation of meninges protrudes through the defect in the posterior arc of the vertebra. The vertebral defect does not involve the spinal cord or nerve roots and may produce no neurologic deficit or symptoms. Meningioceles occur with equal frequency in the cervical, thoracic, and lumbar spine. With cranial meningiocele, surgical repair of the cranial defect affords a good prognosis for most affected infants, whose intellectual and motor functioning is usually normal. The myelomeningocele, your spina bifida cystica, is a hernial protrusion of a sac-like cyst through a defect in the posterior arc of the vertebra. Myelomeningocele is one of the most common developmental anomalies of the nervous system, with an incidence ranging of 0.5 to 1 per 1,000 pregnancies. 80% of myelomeningocele are located in the lumbar or lumbosacral regions, the last regions of the neural tube to close. A blank page. So here we see how your normal, your spina bifida, your meningiocele, and your myelomeningocele may occur. So here you see that. Eumeningocele and myelomeningioceles are evident at birth as pronounced skin defects on the infant's back. The bony prominence of the unfused neural arcs can be palpated at the lateral border of the defect. The defect is usually covered by a transparent membrane that may have neural tissue attached to its inner surface. This membrane may be intact at birth or may leak cerebrospinal fluid, thereby increasing the risk of infection and neuronal damage. The spinal cord and nerve roots are malformed below the level of the lesion, resulting in a loss of motor, sensory, reflex, and autonomic function. A brief neurologic examination concentrating on motor function in the legs, reflexes, and sphincter tone is usually sufficient to determine the level above which the spinal cord and nerve root function is preserved. This is useful to predict if the child will ambulate, require bladder catheterization, or be a high risk for developing scoliosis. So here we have a table, the functional alterations of your myelodysplasia related to the level of the lesion, whether it's thoracic, high lumbar, mid lumbar, low lumbar, or sacral. Hydrocephalus occurs in about 85% of the infants with your myelomeningocele. Seizures also occur in about 30% of those with myelodysplasia. Visual and perceptual problems, including ocular palsies, astigmatism, and visuoperceptual deficits, are common. Motor and sensory functions below the level of the lesions are altered. Often these problems worsen as the child grows and the cord ascends with the vertebral canal, pulling primary scar tissue and tethering the cord. Your myelomeningioceles are almost always associated with a brain malformation, known as a type 2 Arnold-Chiari malformation. This is a complex malformation of the brainstem and the cerebellum, in which the cerebellar tonsils are displaced downward into the cervical spine canal. The upper medulla and lower pons are elongated and thin, and the medulla also is displaced downward and sometimes has a kink. The Chiari 2 malformation is associated with a hydrocephalus from pressure that blocks the flow of the cerebrospinal levels within the spinal canal. Cognitive and motor deficits are common. Your symptomatic Chiari-2 malformation requires surgical decompression or placement of cerebrospinal fluid shunts, or both. Your type 1 Chiari malformation does not involve the brainstem and may be asymptomatic. In type 3, the brainstem or cerebellum extends into the high cervicular myelomeningocele. Type 4 is characterized by a lack of cerebellar development altogether. So here we see type A, the pons, the medulla, the fourth ventricle, cerebral tonsils, and the cerebellum, and the normal brain and Chiari type 2 malformation. So here if you're going to take a look and pause, this way you can review your anatomy. Cannot hurt. Most cases of meningocele and myelomeningocele are diagnosed prenatally by a combination of maternal serologic testing, your alpha fetoprotein, and prenatal ultrasounds. In these cases, the fetus is usually delivered by elective cesarean section to minimize trauma during labor. Surgical repair is critical and can be performed by uterofetal surgery or during the first 72 hours of life. It is possible for a defect to occur without any visible exposure of meninges or neural tissue. This defect, termed spina bifida occulta, is common and occurs to some degree in 10 to 25% of infants. Spinal bifida occulta usually causes no neurologic dysfunction because the spinal cord and spinal nerves are normal. Surgical treatment is usually directed at associated intraspinal abnormalities that occur within the growth of the child, such as a tethered cord, sacral lipoma, or dermoid cyst. A tethered cord syndrome may develop after surgical correction for myelomeningocele. In these cases, the cord becomes abnormally attached or tethered as a result of scar tissue, as the cord transcends the vertebral canal for growth. Traction decreases blood flow and impairs oxidative metabolism. The cord can be untethered surgically. Eucraniosynostono- Eucraniosynostosis, a skull malformation, range from minor, insignificant defects to major defects that are incompatible with life. Eucraniostenosis is a premature closure of one or more of the cranial sutures during the first 18 to 20 months of the infant's life. The incidence of craniosynostosis is 1 in about 2,000 to 2,500 live births. Males are affected twice as often as females. Fusion of cranial sutures prevents growth of the skull perpendicular to the suture line, resulting in an asymmetric shape of the skull. The general term plagiocephaly, meaning misshaped skull, is used to describe deformities that result in craniosynostosis or form asymmetric hand posture. When a single coronal suture fuses prematurely, the head is flattened on that side and in front. When the sagittal suture fuses prematurely, the head is elongated in the anterior-posterior direction and is termed scaphocephaly. Diagnosis of craniosynostosis is made on the basis of physical examination, head circumference, and radiologic examination. Single suture craniosynostosis is usually only a cosmetic issue. Rarely, when multiple sutures fuse permanently, brain growth may be restricted, and surgical repair may prevent neurologic dysfunction. Syndromic craniosynostosis involves deformities in other systems. So here you see, different forms of skull deformity. Malformations of brain development. So, structural malformations of brain are a diverse group of disorders caused by abnormal neuronal migration, abnormal neuronal or glial proliferation. Reduced proliferation or accelerated apoptosis causes congenital microcephaly, and increased proliferation causes megalencephaly. Malformations can occur any time during fetal development or after birth. There are specific genetic defects for some of these disorders. Others are multifactorial or acquired. Most brain malformations increase the risk for seizures, development delay, and motor dysfunction. Your diagnosis is made by clinical history, family history, MRI of the brain. Genetic testing is done for diagnosis to assess the risk in other family members and to guide prospective therapy. Your microcephaly is a defect in brain growth as a whole. Cranial size is significantly below average for the infant's age, sex, race, and gestation. The small size of the skull reflects a small brain. Primary microcephaly is caused by an autosomal recessive genetic defect in one of as many as 16 or more different genes. The secondary microcephaly is associated with various causes, including infection, trauma, metabolic disorders, toxin or radiation exposure, maternal anorexia experienced during the third trimester of pregnancy, and the presence of other genetic syndromes. Your maternal infection with Zika virus causes microcephaly and other congenital malformations, known as congenital Zika syndrome. The current theory is that the virus crosses the placenta barrier, and blood-brain barrier induced neural cell death and inhibiting brain tissue development. So here are some causes of microencephaly. Again, hit pause if it's going a little too quickly. Cortical dysplasias are a heterogeneous group of disorders caused by defects in brain development. These disorders may range from a small area of abnormal tissue to an entire brain that is smooth without the normal gyri or sulci of a developed brain. Specific genetic defects are known for some of these disorders. Others are multifactorial or acquired. Cortical dysplasias increase the risk for seizures that are difficult to control and cause developmental delay and motor dysfunction. Genetic testing assists diagnosis, assesses risk in other family members, and guides therapy. Congenital hydrocephalus is present at birth and characterized by increased CSF pressure. It may be caused by obstruction within the ventricular system, an imbalance in the production or reabsorption of the CSF. Obstructive hydrocephalus is the most common cause by congenital aqueductal stenosis. The cerebral aqueduct, which connects the third ventricle to the fourth ventricle, is narrowed or replaced by multiple channels that end blindly. In a small number of children, the stenosis is transmitted as an X-linked recessive trait that affects brain growth and development, or as non-syndromal autosomal recessive hydrocephalus. The increased pressure within the ventricular system dilates the ventricles and compresses the brain tissue against the skull. When hydrocephalus develops before fusion of the cranial sutures, the skull has the capacity to increase its size to accommodate this additional space-occupying volume and to preserve neuronal function. The overall incidence of hydrocephalus is about 1 to 3 per 1,000. The incidence of hydrocephalus that is not associated with a myelomeningocele is approximately 0.5 to 1 per 1,000. With aqueductal stenosis as the cause for approximately one-third of these cases. So here you see a picture of hydrocephalus. Congenital hydrocephalus may cause fetal death in utero, or increased head circumference may require a cesarean delivery of the infant. Symptoms depend directly on the cause and rate of progression. When there is separation of the cranial sutures, a resonance note sounds when the skull is tapped, a manifestation termed Mason sign or cracked pot sign. Typically, the fontanelles enlarge and become full and bulging. The eyes may assume a staring expression, with sclera visible above the cornea called sunsetting. Cognitive impairment in children with hydrocephalus is often related to associated brain malformations, episodes of shunt failure, or infection. Approximately 30 to 40% of children with uncomplicated congenital hydrocephalus complete schooling and are employed when treated successfully with shunting or endoscopic third ventriculostomy and choroid plexus cauterization. Hydrocephalus caused by CSF obstruction within the ventricular system can result from Dandy-Walker malformations, brain tumors, cysts, trauma, arteriovenous malformations, blood clots, tube infections, and Chiari malformations. The DWM is a congenital defect of the cerebellum characterized by a large posterior fossa, cyst that communicates with the fourth ventricle, and an atrophic upward rotated cerebellar vermis. DWM is commonly associated with hydrocephalus caused by compression of the aqueducts of the sylvius. Alright, so we'll jump ahead to the next section here. Continuing off where we left off here, the cerebrovascular disease in children. The perinatal stroke. Perinatal stroke is estimated to occur in about 1 to 2 in 5,000 live births. Strokes can be either ischemic or hemorrhagic. Neonatal ischemic strokes occur between 20 weeks of fetal life and the 28th postnatal day and are confirmed by neuroimaging or neuropathologic studies. The cause is usually secondary to arterial or cerebrovascular venous thrombosis or the embolization. Intraventricular hemorrhage is a common complication of prematurity and is related to the fragility of an immature vasculature and the hemodynamic and respiratory instability associated with prematurity. Prenatal glucocorticoids are the most effective means of preventing IVH. 50% to 75% of premature infants with IVH develop hydrocephalus, cerebral palsy, and or intellectual disability. Children with perinatal stroke may not be diagnosed until later in infancy or childhood when it becomes apparent that the child is not moving one side of the body as much as the other. Early signs may consist of the family noticing that one hand is preferred over the other at an early age. Typically, handedness does not usually occur until 16 to 18 months of age, or one foot is dragging. An MRI is often performed at this point and is most likely to show evidence of a previous middle cerebral artery stroke. The clinical pattern that usually results from this type of stroke is contralateral hemiplegia, with the arm more affected than the leg. Children with hemiplegia caused by perinatal strokes are prone to seizures, although they generally do well cognitively. Testing for abnormalities in blood clotting mechanisms such as antithrombin enzyme activity, protein C and protein S deficiency, or abnormal factor V Leiden is often performed in children with prenatal stroke. Although often normal, abnormalities in these clotting mechanisms should be assessed because they may make the child prone to further vascular events. So childhood stroke occurs in about 1 to 13 per 100,000 live births. So here there's some risk factors and things to know about strokes in children. Again, hit pause as needed. I'll try to go semi-slowly so you don't have to either pause as much or I can read while you are reading another section as well. Your ischemic stroke. Ischemic stroke is rare in children and may result from embolism, arteriopathy, or rarely sinovenous thrombosis, leading to a decreased flow of blood and oxygen to areas of the brain. Children with arterial ischemic stroke do not have the typical adult risk factors, such as atherosclerosis or hypertension. Roughly 40% of children with an ischemic stroke have no identifiable underlying risk factors. Sickle cell disease, cerebral arteriopathies, cardiac anomalies, and brain infection are the most common disorders that lead to arterial ischemic strokes. Hemorrhagic strokes, congenital cerebral arteriovenous malformations are the most common cause of intracranial bleeding and hemorrhagic stroke in children. Hemorrhagic stroke may result from the vascular anomalies that lead to ruptures such as an aneurysm or from congenital arteriovenous malformations. The rupture of a cerebral aneurysm is rare in children younger than 19 years of age. Intraventricular hemorrhage associated with premature birth is related to immature blood vessels and unstable blood pressure. There is a high risk of developing post-hemorrhagic hydrocephalus. Your Moyamoya disease. Moyamoya is a rare, chronic, progressive stenosis of the anterior circulation, such as the internal carotid arteries and the middle cerebral arteries. Moyamoya is a Japanese term that means puff of smoke, which describes the vascular appearance on cerebral angiograms. The disease is more common among the East Asian population. Moyamoya results from fibrocellular thickening of the intima of the arterial wall of large cerebral vessels. Obstruction of arterial flow to the brain occurs slowly, and neovascularization and increased collateral blood flow to ischemic areas develop. Moyamoya vasculopathy may be idiopathic, associated with certain genetic or metabolic syndromes, or develop as a result of cranial radiation therapy. Complications are developmental, delay, intellectual disability, recurrent ischemic strokes, and cerebral hemorrhage. Treatment is surgical bypass of the ischemic region. Symptoms of ischemic or hemorrhagic stroke may include degrees of hemiplegia, weakness, seizure, headaches, high fever, nuchal rigidity, hemianopia, sensory changes, facial palsy, and temporary aphasia. Your diagnosis of cerebrovascular disease is made through a series of tests, including imaging studies, particularly the MRI. The most important factor in diagnosis is the recognition that children can have strokes, but this possibility is often not recognized. History of evolving neurologic symptoms for less than 12 hours and medical history are the vital importance in obtaining an accurate diagnosis of stroke etiology, although causative factors often cannot be determined. There is no evidence-based treatment for pediatric stroke. Prophylactic medications may be prescribed in those children who have suffered an ischemic stroke. Arteriovenous malformations that may leak and cause hemorrhagic stroke vary in size, location, and symptoms, and these factors determine treatment. If a malformation is present, treatment options include endovascular, surgical, and radiosurgical techniques for embolic occlusion or resection of the malformation. Excellent collateral circulation in the child's brain allows for more rapid recovery of motor function than in adults. The developing brain, however, may suffer more global, long-term effects, leading to intellectual disability, behavioral disorders, and seizures. Epilepsy and seizure disorders in children. Epilepsy is defined as the occurrence of at least two unprovoked seizures more than 24 hours apart. The incidence of epilepsy varies greatly with age, geographic location, and study design. The highest incidence is in children younger than 2 years of age and adults older than 65. Roughly 1,500 persons in the US are newly diagnosed each year. The focus of content in this section is related to children. Chapter 17 already discussed the seizures in epilepsy. Seizures are the abnormal autonomous discharge of electrical activity in the brain. When a sufficient numerous number of neurons become overexcited, they discharge abnormally, which sometimes results in clinical manifestations with alterations in motor function, sensation, autonomic function, behavior, and consciousness. Dysregulation of inhibitory GABA neurotransmission with imbalances of glutamatergic excitatory mechanisms is speculated to be the cause of early childhood seizures. Dysregulation of other types of voltage and ligand-gated ion channels is associated with genetically determined epileptic syndromes. If seizure development, the specific physical activity that occurs depends on the origin of the electrical activity and its extent within the brain. If a child has more than one unprovoked seizure, the child is said to have epilepsy, although there are a few exceptions. For example, being febrile seizures. Seizures can be a result of an underlying disorder, or seizures themselves may be the primary disorder. The latter may have a genetic or familial predisposition. Nearly half of the childhood epilepsy is of an unknown etiology. Seizures and seizure patterns may change as a child grows and develops. The difference between the immature and mature nervous system may help explain the changing patterns of clinical seizures with age. For example, febrile seizures manifest in children 6 months to 3 years of age, and juvenile myoclonic epilepsy is first noted in adolescence. The immature nervous system has a reduced capacity for sustaining well-organized seizures, and therefore, infants are prone to have seizures that occur only in small parts of the body, compared to general tonic-clonic seizures in older children. This is intracortical connection are poorly developed in children, and the sending of impulses through the cortex is limited. At the cellular level, neurons are less capable of firing in repetitive, high-frequency bursts. The excitatory output of seizures focus is further diminished because the affected neurons do not act synchronously. Oh my god. In addition, changing neurotransmitters, immaturity of cells, and ongoing postnatal factors affect seizure expression in children. During the newborn period, asphyxia, intracranial hemorrhage, CNS infection, injury, electrolyte imbalance, and inborn errors of metabolism may cause seizures, despite an extensive search for cause. The etiology often remains unknown. Infants and children may have seizures based on early brain damage, or may manifest specific epilepsy syndromes. Adolescents may have seizures caused by juvenile myoclonic epilepsy or because of the underlying condition. There is an association between autism spectrum disorder and seizures. However, the mechanisms are unclear. The clinical manifestations at the time of seizure vary depending on the primary cause and the extent and involvement of abnormal electrical discharges within the neuronal tissue. Because the diversity and complexity that seizure activity invariably displays, an international classification system was adopted. This classification system groups seizures with similar clinical manifestations. In general, purpose is to assist the clinician with the type of evaluation needed, the identification of the most appropriate treatment, and the evaluation of the individual's response to treatment. Focal seizures are characterized by seizure activity that begins in and usually is limited to one part of either the left or the right hemisphere, and may occur with or without loss of consciousness. The clinical activity displayed is contingent on the particular part of the cortex from which the seizure is generated. For example, focal seizures may result in abnormal motor activity, such as twitching or loss of tone, or sensory changes, such as tingling or numbness. Focal seizures may evolve into general tonic-clonic or atonic seizures. Focal seizures are more likely to be caused by an abnormality in a specific part of the brain, and thus brain imaging is usually performed in children whose seizures have started in a localized manner, even if they generalize later. Possibilities include brain tumors, small areas of localized brain damage, and other causes. Generalized seizures are those in which the first clinical manifestation indicate that the seizure activity starts in or involves both cerebral hemispheres. Because both hemispheres are involved, the clinical manifestations are almost always bilateral. Consciousness may be impaired in this grouping of seizures. The clinical manifestations may include convulsion or convulsive activity, or absence seizures. Generalized seizures are more likely than focal seizures to have a genetic component, although the genetics of some of the epilepsy syndromes have been identified. Many appear to have multifactorial genetic etiology. Childhood absence epilepsy is a type of generalized epilepsy. The age of onset is 4 to 10 years. The genetic causes are unknown and probably multifactorial. It is also can be a sporadic mutations in inhibitory gamma aminobutyric acid A or GABA receptor subunit genes and ion channel genes are associated with absence seizures. The seizures are initiated at a cortical site and spread to other cortical areas and the thalamus. The electroencephalogram, or EEG, shows a characteristic bilateral 3 Hz spike wave discharge. The characteristic absence seizure is of sudden onset and sudden termination, with impairment of consciousness and unresponsiveness, usually lasting less than 10 seconds with no residual defects or deficits. There is interruption of ongoing voluntary activity accompanied by staring, mild eyelid fluttering, and myoclonic jerks. There is no aura. Pallor is uncommon. Seizure may be provoked by about 3 minutes of hyperventilation. Hundreds of seizures can occur per day, disrupting schoolwork and socialization. Behavior, cognitive, and linguistic impairment is common. Anti-epileptic drugs provide beneficial treatment. Your epilepsy syndromes. Epilepsy syndromes are seizure disorders that display a common group of signs and symptoms that occur in a recognizable pattern. Several syndromes associated with epilepsy occur in infants and children. Neonatal seizure, febrile seizure, infantile spasm, the Lennox-Gastaut syndrome, and juvenile myoclonic epilepsy. Neonatal seizures have activity that include rhythmic eye movement, chewing, and swimming movement. These seizures are more often associated with hypoxic ischemic encephalopathy, transient metabolic disturbance, infection, stroke, or intracranial hemorrhage, rather than neonatal onset epilepsies, which may stem from malformation, prior injury, or genetic causes. The immature brain is hyperexcitable and vulnerable to seizure activity. Meticulous effort are required for diagnosis, and there are no standardized treatment guides. Some seizures are self-limiting. Febrile seizures are defined as seizures associated with fever and absence of central nervous system infection. They are divided into two types: simple febrile seizure and complex febrile seizure. Simple febrile seizures occur in 2 to 5% of children. They are benign and the most common childhood seizure. The pathogenesis of simple febrile seizure is unknown. A familial incidence of simple febrile seizure indicates a genetic predisposition. Factors that contribute to susceptibility include age, degree, rate of temperature elevation, and nature of the particularly fever-inducing illness. Any disorder producing a high fever may provoke benign febrile seizures in susceptible children. The following characteristics distinguish simple febrile seizures from complex precipitated by a fever. Simple febrile seizures usually occur between 3 months and 5 years of age. The convulsion occurs with a rise in temperature to greater than 39 degrees Celsius. An acute respiratory tract or ear infection usually is present, with no evidence of CNS infection or inflammation. Most seizures occur within the first 24 hours of the illness. The convulsion is usually short, 15 minutes or less, generalized, and predominantly tonic. Interictal EEG is normal. The seizure usually does not recur during the same infection, and no acute systemic metabolic disorder is present. Complex febrile seizures have characteristic features similar to those of a simple febrile seizure, except that they have a longer duration than do benign febrile seizures, usually longer than 15 minutes. They have focal characteristics confined to one side of the child's body, and they usually occur more than once in a 24-hour period. The link between complex febrile seizures and the development of epilepsy continues to be evaluated. For febrile seizures, the cause of the child's fever should be determined, and meningitis should be considered in the differential diagnosis. Medications for preventing recurrence of simple febrile seizures is rarely used because side effects outweigh benefit. Infantile spasms are a severe form of epilepsy characterized by a variety of clinical manifestations. Children with infantile spasms have episodes consistent of sudden flexion or extension involving the neck, trunk, and extremities. Infantile spasms in some children are caused by underlying brain abnormalities, such as intrauterine stroke or tuberous sclerosis, whereas others may be caused by mutations in one of several genes. Clinical manifestations of the resulting spasm may range from a subtle head nod to violent body contractions, commonly referred to as jackknife seizures. Onset of infantile spasms usually is between 4 and 8 months of age and may be idiopathic or may occur in response to a CNS insult. An EEG will display the classic hypsarrhythmic pattern on a slow, disorganized background. After infantile spasm begins, there's usually a typical clinical course. The spasm usually occurs in clusters and happen 5 to 150 times per day. They are usually worse when the infant is waking up or falling asleep. Once begun, the seizure activity increases in intensity and severity over time. Invariably, a loss of developmental milestones and disability is associated with this syndrome. A short-term course of adrenocorticotropic hormone, or prednisolone, is effective in many cases of infantile spasms. Infantile spasms are present in about 30% of children with tuberous sclerosis complex, or TSC. TSC develops from autosomal dominant mutation in hemeritin found on chromosome 9q38, or tuberin TSC genes found on chromosome 16p13. Tubers are critical development malformations in the brain. They also form in other organs. Your epilepsy associated with TSC is often difficult to treat. Steroid or vigabatrin, which may cause vision defects, are medications of choice for children with infantile spasm, attributable to tuberous sclerosis because they seem to be particularly effective in these children. Epilepsy surgery also may be effective. Your Lennox-Gastaut syndrome is an epileptic syndrome characterized by the onset of seizures early in childhood. It occurs in males more often than females and begins between the ages of 1 and 8. This syndrome includes a variety of generalized seizures, predominantly tonic-clonic, atonic, akinetic, absence, and myoclonic activity, and the specific pattern on EEGs. Seizures associated with the syndrome are usually very difficult to treat. Children may be prescribed multiple medications and alternatives, such as ketogenic diet, vagal nerve stimulation, or epilepsy surgery, although children may be developmentally on track when the seizure begins. Development is usually affected and the future manifestations of intellectual disability is common. So there is a nutrition and disease. Again, feel free to pause if I'm going too quickly through this section. Juvenile myoclonic epilepsy, or JME, is a primary generalized epilepsy that usually affects adolescents and young adults. Genetic factors are complex and are still being clarified. JME is a relatively benign form of epilepsy, involving myoclonic jerks of the neck, shoulder, and arms, as well as generalized tonic-clonic seizures. Myoclonic jerks typically occur after awakening. The seizures may occur singularly or repetitively. This form of epilepsy is common, associated with a normal neurologic exam, normal intelligence, and family history of seizures. Cognitive impairment and psychiatric disorders have been reported. Because clinical features can be subtle, GME is likely to be underdiagnosed. Children with this syndrome will usually need to be will usually need to take medication for life, but with appropriate treatment, seizures are well controlled. Your childhood tumors, brain tumors, are the most common solid tumor and cause of cancer death in children. Roughly 45% of primary brain tumors in children are non-malignant. Overall, primary brain tumors account for nearly 26% of all childhood cancers, with an annual incidence of 5.37 per 100,000 for primary malignant and non-malignant tumors in the US. Many non-malignant brain and CNS tumors are not histologically confirmed, and reporting varies across cancer registries. Survival at 5 years of primary malignant brain tumor for ages 0 to 19 years of age is 73%, varying significant by tumor type, and there's often significant morbidity. So there's a little spot on what's new on childhood brain cancer. Feel free to pause if you wish to read it. Primary brain tumors arise from the brain tissue and do not metastasize outside the brain. The cause of brain tumors is largely unknown, although genetic, environmental, and immune factors have been investigated. Exposure to ionizing radiation has been the only environmental factor consistently related to the development of brain tumors. Your pathophysiology, brain tumors can arise from the CNS, cell and are classified by cell type. Medulloblastoma, epitheliomyoma, and astrocytoma, brainstem glioma, craniopharyngioma, and optic nerve glioma constitute about 75 to 80% of all pediatric brain tumors. Germ cell tumors are typically rare. Two-thirds of all pediatric brain tumors in children are located in the posterior fossa. Brain tumors spread by direct invasion or dissemination of cells through the CSF. Specific characteristics, treatment strategies, and prognosis are listed in the following table. So here you see the location and approximate percentage of brain tumors. Again, pause, take a look so you can see where they're at. And this following table shows the brain tumors in children. So the type, characteristic, the treatment, and your overall prognosis. Again, hit pause as needed. Try to keep as much of it all in one spot so you don't have to pause a couple times. Brain tumors, by virtue of their location, have unique characteristics that distinguish them from tumors found elsewhere in the body. A number of brain tumors in children may be considered histologically benign, yet clinically malignant and life-threatening because of their location. For example, a tumor located in the brainstem may appear benign under the microscope, but the clinical presentation threatens and all too often overrides the vital function of the brainstem. Clinical manifestations. The location of the brain tumor, cell type, and rate of growth dictate the presenting signs and symptoms. The ability of the brain and intracranial cavity to compensate for tumor growth is directly related to the rate of its growth. The compensatory mechanism allowing the component of the intracranial space to adapt temporarily to slow changes in increased intracranial pressure. Therefore, slow-growing tumors can grow to enormous size before signs and symptoms are apparent. Conversely, fast-growing tumors allow little time for compensation of the space-occupying lesion, and clinical symptoms occur quickly. Clinical symptoms may range from changes in personality to paralysis, depending on the location of the tumor. Signs and symptoms of brain tumors in children vary from generalized and vague to those that are localized and related specifically to the area of the brain involved. If the tumor is located in the posterior fossa, The fourth ventricle may become blocked, which leads to obstruction, hydrocephalus, and signs of increased ICP. The symptoms of increased ICP include headache, vomiting, lethargy, and irritability. If a young child complains of repeated and worsening headache, a thorough investigation should take place because headache is an uncommon complaint in young children. Headache caused by increased ICP usually is worse in the morning and gradually improves during the day when the child is upright and venous drainage is enhanced. The frequency of headache and other symptoms increase as the tumor grows. Irritability or possible apathy and increased somnolence also may result from increased ICP. Like headache, vomiting occurs more commonly in the morning. It is often not preceded by nausea and may become projectile. Differing from a gastrointestinal disturbance, the child may be ready to eat immediately after vomiting. Other signs and symptoms that can accompany increased ICP include increased headache circumference with bulging fontanelles in children younger than 2 years of age, cranial nerve palsies, and papilledema. Localized findings relate to the degree of the disturbance in physiologic functioning in the area where the tumor is located. Children with infraterritorial tumors exhibit localized signs of impaired coordination and balance, including ataxia, gait difficulties, truncal ataxia, and loss of balance. Medulloblastoma and epidediomyoma are embryonal tumors. Medulloblastoma is the most common, develops in the vermis of the cerebellum, and may extend into the fourth ventricle. Angiogenesis is the hallmark of progressive medulloblastomas. Subclassifications based on the histopathology and genomics are contributing to targeted therapy. Ependymyoma develops in the fourth ventricle and arises from the ependymal cells that line the ventricular system. Because both tumors are located in the posterior fossa region along the midline, presenting signs and symptoms are similar, and they are more likely to spread throughout the neuroaxis. In contrast, cerebellar astrocytomas are located on the surface of the right or left cerebellar hemisphere and cause unilateral symptoms such as a head tilt, limb ataxia, nystagmus, when the eyes are turned toward the side with the tumor. Brainstem gliomas often cause a combination of cranial nerve involvement, ataxia, corticospinal tract dysfunction. A common clinical pattern includes unilateral paralysis of cranial nerves with contralateral paralysis of one arm and leg, hyperreflexia, and extensor plantar responses. Increased ICP can occur if there is expansion of the pons. The area of Silla turcica, the structure containing the pituitary gland, is the site of several childhood brain tumors. Most common in this group is the craniopharyngioma. The tumor originates from the pituitary gland or hypothalamus. Usually slow growing, it may be quite large at the time of diagnosis with compression of the pituitary gland and hypothalamus, and increased intracranial pressure. Symptoms include a headache, seizure, diabetes insipidus, early onset puberty, and growth delay. Other tumors located in this region of the brain include optic gliomas. Optic nerve gliomas are associated with neurofibromatosis type 1, a neurocutaneous condition characterized by a cafe au lait macules on the skin and benign tumors of the skin. Tumors that involve the optic tract may cause complete unilateral blindness and hemianopia of the other eye. Optic atrophy is another common finding. Supratentorial tumors of the cerebral hemispheres are more common in neonates and adolescents. Epilepsy astrocytomas are the most common supratentorial tumors. These are localized grade 1 slow-growing cyst-filled gliomas that are often completely removed surgically with very high survival rates. Tumors located in the cortex may cause focal cerebral dysfunction, weakness, hemiparesis, seizures, and visual changes. Involvement of particular lobes may result in a more specific localized symptom. For example, a tumor located at the frontal lobe may cause changes in affect and behavior, and a tumor in the occipital lobe may cause cortical blindness or blindness in half of the visual field. So are evaluation and treatment. A child with signs and symptoms of a brain tumor require a complete workup, including neurologic, development, and ophthalmic examination. CAT scan with contrast enhancement allows direct visualization of the tumor mass. MRIs provide advanced high-resolution exams of the brain and neoplasm. Small low-grade tumors not seen in CT may be detected by MRIs. and MRA is very helpful in assessing the vascularity of the tumor and its relationship to major blood vessels. Spine MRI exam may be used to evaluate tumor dissemination along the spinal column. Lumbar puncture to examine CSF for tumor cells also may be performed. Histochemical and molecular genetic analysis of the tumor tissue assists with tumor classification. The most useful treatment for brain tumors is surgical resection. Surgery is important to establish the diagnosis, reduce tumor size, and relieve tumor compression and obstructive hydrocephalus when present. Some brain tumors, such as low-grade cerebellar astrocytomas, may be cured with complete resection alone. Contraindications to such interventions are tumors in which surgical resection and biopsy carry a high risk of mortality or serious morbidity. In these instances, diagnosis is made on the basis of radiologic evidence and clinical manifestations. Most brain tumors require additional radiation and chemotherapy. Although these treatments are essential for potential eradication of the brain tumor, radiation to a young child's brain is associated with significant morbidity, including acute and long-term sequelae. Prognosis varies according to type, classification, location of the brain tumor, and age of the child. Historically, survival rates have been very low. However, advances have been made with the combination of surgery, radiation therapy, and chemotherapy. High-dose chemotherapy with autologous stem cell rescue has been used for treatment of resistant tumors. Advances are being made in the area of immunotherapy and targeted molecular therapy. Comprehensive care and management of these children and their families is vital. Multidisciplinary teams enhance the continuity and consistency needed to care for the children and their families. Neuroblastomas is an embryonal tumor derived from neural crest cells that form the adrenal medulla and the sympathetic nervous system. Neuroblastoma involves a defect of embryonic tissue and is the most common extracranial solid tumor in infants less than 1 year of age. 75% of neuroblastomas are found before the child is 5 years old, and onset after 10 years of age is very rare. Occasionally, these tumors have been diagnosed at birth, with metastasis apparent in the placenta. The incidence is about 10.54 per million per year in children younger than 15. Black children are more likely to have high-risk disease and fatal outcomes. Roughly 70% of children with neuroblastomas have metastatic disease at diagnosis. Neuroblastomas are heterogeneous and can spontaneously regress or become highly metastatic, with low, intermediate, or high risk for recurrence. Prognosis is worse for children older than 2 years of age with disseminated disease. Neuroblastoma is sporadic in most children. Familial cases of neuroblastoma are considered to have an autosomal dominant pattern of inheritance. Ganglion neuroblastomas are localized tumors of an intermediate level of cellular differentiation, composed of mature ganglion and myelin sheath. The most differentiated tumor is a ganglioneuroma. which is considered benign and does not metastasize. They are usually surgically removed. Excuse me. The pathophysiology. Neuroblastomas arise from neural crest tissue, and the mechanism are not clearly understood. Both genetic and epigenetic events are involved. The most common location of neuroblastoma is the retroperitoneal region. Most of the adrenal medulla, the tumor, is evident as an abdominal mass and may cause anorexia, bowel and bladder alteration, and sometimes spinal cord compression. The most common location of neuroblastoma is mediastinum, where the tumor may cause dyspnea or infection related to airway obstruction. Less commonly, neuroblastomas may arise from the cervical sympathetic ganglion. Cervical neuroblastomas often cause Horner syndrome, which consists of meiosis, ptosis, enophthalmosis, and anhidrosis. Neuroblastomas present with neurologic syndromes called the opsoclonus myoclonus syndrome. So clinical manifestations. A number of systemic signs and symptoms are characteristic of neuroblastoma, including weight loss, irritability, fatigue, and fever. Intractable diarrhea occurs to 7 to 9% of children and is caused by tumor secretion of a hormone called vasoactive intestinal polypeptide. More than 90% of children with neuroblastoma have increased amounts of catecholamines and associated metabolites in their urine. High levels of urinary catecholamines and serum ferritin are associated with a poor prognosis. So are evaluation and treatment. Initial diagnostic studies are dictated by the location of the primary tumor. Diagnosis begins with a complete physical and neurologic examination. Laboratory analysis include a measurement of levels of urinary catecholamines, plasma ferritin, serum neuron-specific enolase, an enzyme produced by neuronal tissue, and gangliosides, lipid molecules that may be shed from the surface of tumor cells, and bone marrow biopsies. Imaging studies assist with localization. The diagnosis of neuroblastoma is confirmed by surgical biopsy and histopathologic results. Antenatal ultrasound may detect the tumor in the antenatal period. Treatment is based on the extent of the disease and prognostic markers, such as age, MYCN copy numbers, chromosome 11q status, DNA ploidy, and high serum ferritin or NSE levels. Low-risk disease is treated surgically. Chemotherapy is used if there is recurrence. Intermediate-risk tumors are treated with surgery and chemotherapy. High-risk neuroblastomas are treated with high-dose chemotherapy and radiotherapy, followed by transplantation of purged autologous bone marrow. Monoclonal antibody-based immunotherapy has been shown to be effective for high-risk tumors. Approximately 50% of children with high-risk disease will die despite intensive therapy, although this percentage is improving. Retinoblastoma. Retinoblastoma is a rare congenital eye tumor of young children that originates in the retina of one or both eyes. Retinoblastoma can be either inherited or acquired. The inherited form of the disease generally is diagnosed during the first year of life. The acquired disease is most commonly diagnosed in children 2 to 3 years of age and involves unilateral disease. Approximately 40% of retinoblastomas are inherited as an autosomal dominant trait with incomplete penetrance. The remaining 60% are acquired. About 200 to 300 children are diagnosed in the US each year, and 1 in 4 cases involves both eyes. So pathophysiology. In the early 1970s, Knudsen proposed the two-hit hypothesis to explain the occurrence of both hereditary and acquired forms of the disease. This hypothesis predicts that 2 separate transforming events or hits must occur in a normal retinoblast cell to cause the cancer. Further, it proposes that it is an inherited form. The first hit or mutation occurs in the germ cell, and the mutation is contained in every cell of the child's body. Only a second, random mutation in the retinoblast cell is needed to transform that cell into cancer. Multiple tumors are observed in the inherited form because the second mutation are likely to occur in several of the approximate 1 to 2 million retinoblast cells. In contrast, the acquired form of retinoblastoma requires two independent hits or mutations to occur in the same somatic cell for the transformation to form. This is much less likely to happen, and the following figure illustrates the two mutation models for these two patterns of mutation. Tumor formation usually begins with the mutation in both alleles of the retinoblastoma tumor. Suppressor gene RB1, which codes for retinoblastoma protein. Retinoblastomas grows as one or more tumors in the retina and extends into the vitreous humor. Free-floating small tumors in the vitreous humor may attach to the surface of the retina in the multiple areas of proliferate and detach the retina. The tumor can also invade the optic nerve by infiltrating the cribriform plate of the ethmoid bone, or can spread through the sheath around the nerve. In either case, the tumor can gain access to the subarachnoid space in the CNS. The tumor spreads into the choroid in 25% of the children with retinoblastoma. Because the choroid is highly vascular, metastasis by means of hematogenous spread is possible. When hematogenous spread occurs, metastatic sites including the bone marrow, long bones, lymph nodes, and liver can occur. If the tumor invades the orbit, lymphatic spread is possible. Spontaneous regression occurs, although infrequently. It may be caused by the tumor outgrowing its blood supply. So, clinical manifestations. The primary sign of a retinoblastoma is leukochoria, a white pupillary reflex, also called the cat's eye reflex, which is caused by the mass behind the lens. This is easy to identify, sign can be missed. Other signs and symptoms include strabismus, a red, painful eye, and limited vision. So our evaluation and treatment. Because retinoblastoma is a treatable tumor, the priorities are saving the child's life, preservation of the eye, restoring useful vision. Diagnostic evaluation for retinoblastoma include documentation of family history, complete ophthalmologic examination, a metastatic study that includes bone marrow aspiration, lumbar puncture for the spinal fluid examination, bone scans, MRI scans. Because of the potential hereditary risk to a child's sibling, all siblings younger than 4 years also should receive ophthalmologic evaluations. Treatment is related to tumor stage, number of tumor foci, and unilateral or bilateral disease, vitreous seeding, and age of the child. The need for enucleation has been significantly reduced with the use of intra-arterial chemotherapy. The prognosis for most children with retinoblastoma is excellent, with greater than 90% long-term survival, although children with bilateral or metastatic disease at diagnosis have poor prognosis. Roughly 75% of the children have useful vision in the treated eye. Children with bilateral disease need to be monitored for the development of other cancers. That concludes our chapter here, and we'll see you at the next one. Till then, stay safe and be well.